So our next presentation is on the very important topic of biomarkers, and I want to introduce our speaker on that topic. So Robert Baird. Robert has extensive experience in healthcare management and developing strategic plans and directing financial, operational, and clinical initiatives. He is currently the president of the National Cancer Treatment Alliance, which is a national network of community oncology practices whose focus is to contract directly with healthcare purchasers for oncology services. Before joining NCTA, Robert was the CEO of Dayton Physicians, where he merged 3 independent physician practices to create a large multi-specialty practice. So Robert is not far away in the Dayton area, and it's a pleasure to have him here with us today. So you can take it away, Robert. Thank you.
All right. Well, thanks everybody, and thanks for inviting me out here to talk about this. And I think we had a good lead in from Jason and Cody about really the importance of biomarker testing. And as Jason said, cancer is unique to every individual. So the same treatment for one patient might not work on on another patient. And what we are trying to support is really providing the education on those tools that a physician can use to really make sure that treatment is targeted and focused. And I am the president of the National Cancer Treatment Alliance. We're part of a larger organization, the Community Oncology Alliance, which is a national association that really supports patients, supports physicians, supports practices, really on legislative, also advocacy, and also really support options and really educational components. So that's one of the things we're really trying to do is provide awareness. So one of the things the National Cancer Treatment Alliance did is put together an employer toolkit. And we did a lot of presentations, and I'll get into that. So I'm going to give you show you what resources we provided that you guys can have access to. So as was talked about, cancer is really doubling and really an expensive disease. It's really in the top 5 and sometimes the top or top 2 in an employer's expenses. It's something they really don't think about a lot because it's usually not a lot of patients, as Cody showed, but the financial impact and the impact on those employees can be really great in terms of mental health and other areas. So U.S. spending has doubled, and really it's even greater than 12% sometimes of an employer's bottom line, and as part of their benefit costs. And really, a lot of the cost is, as we talked about, with new technology, new therapies coming out, those medications are becoming very expensive, but very effective also in terms of eradicating cancer. So we want to make sure that the message out there is you're doing the right testing on the right person to get the right treatment at the right time. So this is really the pathway, and this is it's a high level, this is pretty standard across the board on how treatments are done. The cancer is diagnosed, through a biopsy or something like that by a pathologist, by a physician, depending on which type they have. And the mutation's detected, hopefully through a biomarker screening test. Target therapies determined, leading to a greater and more successful patient outcome. Lower cost, healthier patient, still being able to still being very productive in an employer organization. So really, it's all about access. There's been a lot of evolvement and a lot of advances in biomarker testing. There's, single gene tests, there's comprehensive tests, there's stuff in between. The focus we have really put on is really trying to provide a broad panel of testing instead of a single test, doing these, targeted tests and single tests, sometimes 2, 3, 4, 5, might not give you the whole answer. I was just at a conference last week where the presentation was about a screening test for lung cancer, and there's really 22 mutations that should be tested for. And so the presenter showed a scatter diagram of all the companies out there that are providing, this type of lung cancer testing, and only one of them really tested for all 22 of those mutations. And then when he would go back to the employers he was working with and say, who are you covering and how are you covering these tests? They really had no idea. Some were covering the company that provided all the testing, some didn't, some covered it all, some covered none. So we're really trying to make sure the employers have the tools to get these patients the appropriate testing they need so the targeted therapy can be determined. So again, the oncologist evaluates symptoms, does a biopsy, and really it's step 3 where we're trying to provide some education. Broader panel testing versus single testing, really knowing exactly what you're covering and exactly what's going on. And it leads to more informed decisions on targeted therapy options and those treatments that are coming. I think we've seen, heard some good examples from both, presenters before on how those treatments can be very effective and very life-changing and life-saving. So what happens when you don't do a comprehensive test? Sometimes you can get inconclusive results, incomplete information, and really extra procedures. There's been many examples that I've heard where patients have, for a variety of reasons, have started on a treatment option, didn't really work for them. Physician says, oh, we probably should do some testing, does the testing, and then finds out, a more effective therapy could be better for that patient. But they've already started the treatment, they've already incurred that expense, they may be dealing with some side effect issues. So really it's that collaboration and that really understanding of getting the information to the physician to make sure they know how to use those. And we'll get into some of the complexities around that here in a minute. But again, we're still promoting more of a larger panel of biomarker testing. And also on that last slide, the rebiopsy is very challenging. When I was with the physician group prior, we would have the pathology come, and you have to go back to the hospital to find the pathology, get the tissue. Sometimes there wasn't enough tissue left. You could have to rebiopsy. Now you can do some blood biopsies that are coming out that might work, which is a whole other story. But sometimes it could lead to really long treatment delays for those patients, and that's really not what you wanted, not the best outcome for a patient. So the more comprehensive tests can lead to more patient-centric care, reduce toxicity, again, by removing some of the barriers that I just talked about, really improve quality of life. Chemotherapy, traditional chemotherapy, and a lot of these drugs really have side effects that really need to be effectively managed, and patients react to them differently. So really that quality of life, when you can still maintain an active lifestyle, still go to work, those things like that, still feel better and reduce and remove some of those toxicities. It also gives us, more information on clinical trials, and we're going to touch on that. As we've talked about, clinical trials is really the way that new drugs are developed, and comprehensive biomarker testing can actually give the information better to a physician to know which trials the patient can be eligible for. There's, information now coming into the EHR when the biomarker is picked up that it presents those clinical trial options to a physician real time. And, companies like Access Hope or Cancer Bridge can also help support those initiatives also. And again, we're focusing on reduced overall costs, going back and making sure you've got the right treatment, the right time, avoiding unnecessary and expensive treatments potentially. And there might be options where, a targeted therapy where there really isn't an option. So, you're avoiding having to do some of those where a targeted therapy may not work. So you might have a different discussion with that patient. So really, this is an old study, but it still showed that there's still a lot of work to do in terms of biomarker testing and making sure those tests are done. The practice I was with before, it was hit or miss. We had the old 80-20 rule that 20% of the providers were doing 80% of the testing, and really trying to make sure that everybody was doing this standard across the board. So now you're seeing a lot of these tests put in a lot of this, putting to care plans with the physician. So it's got the diagnostic workup, also the testing, the imaging, the treatment options, and everything all in one care plan to make sure nothing is missed. So I think there's been a lot of evolution there also. And then this shows, again, just what we talked about, that really there is some opportunity for biomarker testing leading to a clinical trial. But as you see right here, many patients had biomarker testing but didn't get into a clinical trial. So I think access to clinical trials, like Cody's organization, Genentech does, because that's really where the research is. And sometimes it's a better option not only for the patient, but also can reduce some of the costs for the employer and the employee. But many times, and the clinical and trial enrollment is very challenging to do. Sometimes you're just relying on that physician with everything they've got going on to remember which clinical trials are out there. So you really have to also make sure you've got that support system in place with nursing, with organizations that can help remind those doctors before and remind those patients that there is a clinical trial opportunity that might benefit them. There's also, we did some follow-on research, and again, looking back at health equity, we partnered with a data company who had access to national claims data and really looked and saw what happened. And really, in African Americans, Asians, others, there's really a lot of work that needs to happen, particularly on the health equity front, to make sure the clinical trial access is equal to everybody. And I think that's something that an employer can really promote and really help push that. That really you want to make sure you've got access to everybody, because some might have transportation issues, financial issues, support issues, being at home with being, with not having really a support network or a caregiver at home. So these things, we haven't solved for that. We're just trying to bring this awareness out. So there's really a lot of work that has to be done on the health equity side. A lot of the employers and business groups we've talked to have really started to think about health equity issues, just kind of bringing awareness to it, a lot on the mental health side, a lot on the dietary side. But many of the practices that we work with and support really do spend a lot of time finding resources for patients in terms of social work, transportation, helping with other expenses through foundations and things of that nature. So one of the things that we've really tried to educate employers on is really looking at what benefits they have and how they've designed their benefit for biomarker testing coverage. And these are some of the considerations that we've recommended. So when you go back and you look where kind of the access points, and this again is some additional information we received. So where are these barriers created and how can you overcome that? When we started this information, we really didn't know about a lab benefit manager. They kind of are behind the scenes. We know about the pharmacy benefit managers, and there are actions going on to raise awareness and kind of remove some of those obstacles. But we really didn't know about the lab benefit managers who make these medical coverage decisions and medical coverage policies for a plan that an employer might not even know about. They might just ask, is biomarker testing covered? And the answer would be, well, yes, we have coverage for biomarker testing, but is that a detailed enough question? So you really need to make sure you know who's making these decisions behind the scenes with your TPA or your plan that you're using. And then the benefit consultants, and that's very important. Many of the consultants that we talk to don't really know, it's not really on their radar screen about biomarker testing coverage, so they don't think about it. So they might not bring it up, or they might not ask a question or tell an employer, I've looked into your plan and here's my recommendation. And also the business groups, a lot of them, the Midwest Business Group on Health that we work closely with, the National Alliance, Cancer Care, they've all done work on trying to educate employers on biomarker testing and how this can be, reduce costs, but also provide high quality and great access for patients. And then the practice managers, they feel they really want this opportunity. They want this done for their practice. They want this done for their patients. Their physicians want it. So they really are trying to promote this, but it gets very confusing. There's a lot of testing companies out there, and a lot of times getting access into the EHR is a challenge. I know there was just an announcement. Many of the practices that we work with use a Flatiron product. So there we go, Onco EMR. So I know there was just an announcement made where Foundation Medicine and Garden Health now are going to be able to provide that data into the electronic record real time so that a physician has greater and quicker access in a better location to find that information. Again, trying to streamline this process to get the information to the physician about their patient, what's the right treatment at the right time, and possibly a clinical trial. And again, a lot of this has to do with just the rising costs of specialty medications. As you can see right here in this data, a single gene test, so it might cost $500 to get that test done. And $1,000 for a limited panel, maybe $3,000 to $5,000 for a comprehensive profile. But if you can avoid or ensure that you're going to be spending on average, $170,000 for that targeted therapy. Is that a good $5,000 investment? Is that a good return on your investment to make sure that you're making the right choice, or to make sure that you might need to make a different choice depending on what that could be? But the key is making sure you've got access to that genomic or biomarker testing. One of the issues that just came up is Medicare, makes a lot of coverage decisions that companies look at and all this. Well, I think the physician fee schedule was just actually released today, but I haven't looked. But part of the laboratory piece of that physician fee schedule was an 80% cut on the reimbursement side to the Medicare coverage for genomic testing or biomarker testing. Now, physician practices they provide this information, they provide the testing opportunities, but they don't buy and bill per se these tests. They're usually sent to outside companies. But if those outside companies can't get reimbursed at the level that they need to cover their costs, with an 80% cut to these codes, they're going to stop doing it. And it's just not going to be accessible. So physicians and other providers rely on getting access to these tests. And I'm not sure, I didn't go back to look this morning to see if that went through or not. But, those are the types of things that we really are trying to promote and really bringing awareness to. Because I think there's shared responsibility. So as you can see right here where the crossover is. So, health plans want to look at their per member per month cost. They want to make sure they're looking at total population health. They want to make sure that physicians and other providers aren't really overutilizing these tests. So they want to make sure it's reasonable and necessary. Employers are looking at, their cost of their employer and the employees. So they're looking at their bottom line, but also making sure that their employees are healthy, productive, and being as productive and being able to come to work as much as possible. But as you can see, there's overlap. So there's cost management overlap. Everybody wants to improve outcomes, but also the insurance plan wants to make sure that member stays with them, and the employer wants to make sure that employee stays with them. So they've all got vested interests to work together. So again, employers should be talking, and really the consultant should be helping with this, talking to their employers about what are your plan's biomarker testing policies? Do you really know what they are and what's covered and what's not? What are you doing to ensure that those tests that are ordered are comprehensive in nature? And also, why are you not covering certain FDA products? And I know we had a conversation this morning about, coverage of biomarker testing, from some of these tests, and some of these companies aren't FDA approved, but they're still beneficial and they're very effective. And again, improving coverage, particularly for clinical trials. Again, that's the lifeblood. All the practices we work with have access to clinical trials, whether it's through their own practice, an organization they work with, or another center, an NCI designated center that's close by. But the oncologists have access to clinical trials that can be available for patients and employers alike. And again, it's all about getting the right treatment to the right patient as fast as possible, making sure that you've got the best chance for outcomes. So that's just very important. So we did develop an employer toolkit. It's a high-level toolkit. It's available on our website at the National Cancer Treatment Alliance. We put together some high-level information. We did a whole series of webinars. I think we did a lot of speaking engagements when we rolled this out. We had our Chief Medical Officer, Dr. Fred Schnell, do a lot of these presentations. The one thing that we did, because we started this toolkit we did a lot of it last year, did a lot of presentations, and we're kind of picking up and delving into that research. But we get asked the question all the time, and we've talked to a lot of the employers and business groups about we presented this to. And the challenging thing was we handed them the information. We tried to hit the easy button and make it as easy for them as possible. But in our follow-up conversations, they lost sight of it. I think, you've got a benefit manager, someone who's in charge of the HR functions, getting hit with many things, and this just isn't on their radar. So it takes a lot of information, a lot of education, and really multiple times to visit. We tried to get some of the data to see if there was an uptick in potential, utilization and access to these tests. It's just very challenging to get that data. But in our conversations, it was kind of disheartening, for lack of a better term, to say we spent all this time, we did all these things, we talked to so many people, and really to come back and say, did you act on this? The majority of them really didn't. They were excited about it at the time. They left the meeting, they got in their car, and then got busy with other stuff, which is typical. So it's just, circling back on that. But I think that's where, Employers Health can help pull in and make sure these things are top of mind and very important, but also understanding how these things can also work together to really improve outcomes and reduce costs. So we put together a webinar, a checklist, an action brief, and then a little infographic, a really high-level infographic to really show in a snapshot what some of these things can do. So this is our little infographic here, and it really just shows how many steps and what the cost in terms of the dollar sign could be in terms if you have to do a single gene test and then do another single gene test and then maybe start a treatment, maybe have to stop a treatment. As you can see, the cost builds up. There's multiple steps in that. You might have to do a new biopsy, a rebiopsy, a liquid biopsy at this point. It's bringing that patient back who, again, might have transportation issues. They might have support issues. They might not have friendly, off work policies to get all this stuff done. So they're concerned about it. So trying to get to the right test and to the right treatment quicker can help save money. As you see right here, as you can read all this. So, you do a biopsy, a complete genomic test. It's, they come back positive, but with a rare mutation the physician can act upon. And then you start treatment quicker with, a more targeted therapy that's going to work better on you as an individual than another therapy may. So again, saving costs and improving outcomes. But it's really getting that message out there. So we put together a toolkit also, or an example of checklist questions. And we've expanded this also because we've added some components on, health equity and things like that. But really, does your policy cover all tests that are FDA approved? And do they match to an approved treatment? That is another thing that we found out also during this research during this journey, is that you might have a biomarker testing, but there's been a lot of work. A lot of these new drugs coming out have a companion diagnostic, and it's specific to one company and one test. And maybe that one test or that one company is not covered on your plan. So now you've all of a sudden created a barrier that you really didn't mean to or know about. So it was interesting to find that information out. And then does it cover all the genes in any given tumor type? And what about, what if you did have a non-FDA approved plan or a non-FDA approved test? And then you're just trying to make sure they understand a lot of these decisions they make on the benefit side can really impact access and increase the time it takes to treat patients. So you really want to do what you can to reduce delays. And then also clinical trials. When we talk to a lot of the employers, some of these, they still view clinical trials, and not everybody, but look at that as an experimental therapy, or it's, and they just don't cover it because it's considered experiment. But really, particularly in oncology, clinical trials and access to clinical trials is the lifeblood of really putting, getting new treatments out there that can be more effective and life-changing, and again, life savings. So I'll run through this. So we did do this with a sponsor, so we thank them for that, and then just try to answer any questions at this point. Oh, I did great.
Hi, Robert. Cody from Genentech. Thank you. And I'm really interested, actually, like the next step questions, like the list of questions you had up there, I think we'll take and send those on. But the lung cancer screening that you had talked about, the biomarker screening, and then the fact that there's all these tests, but only one of them actually does all of the screenings and all the biomarkers. Like, where do we find that information as employers so that way we can ask those right questions and potentially do steerage to the right test?
I think it's utilizing the network of practice, whether you contact the National Cancer Treatment Alliance or Cancer Bridge or Access Hope. I think it's just making sure that you're informed. So we're trying, all of our organizations are out there just trying to be a resource to employers, a resource to employees, and a resource, again, to consultants who help people make those decisions. So really, I think the key is making sure you might not know, but making sure you reach out. Don't be afraid. If you've got this relationship built, you know one of us, you can call the 1-800 number, just reach out, ask the questions. We'll definitely get, the experts on the phone. Our medical director spends a lot of time doing things like this, just getting, answering emails, questions specific about all kinds of things, but he does a lot on biomarker testing also. It's one of his passions. But I think it's using the network and the resources that are available to you as an employer.
Yeah, thank you, Robert. Matt Harmon here at Employers Health. So I think you had the stat that about 30% of patients with breast, prostate, or lung cancer did not receive some sort of biomarker testing prior to their first treatment. So that's pretty eye-opening statistics. So I know a lot of times we think about prior authorizations as potentially a barrier, but could they, or look at them more of a facilitator to ensure that some of the testing is done, or do you have an opinion on which way that you would land with prior authorizations?
Well, I think prior authorizations is a burden on practices. And so many of the things that are going on right now in oncology or at the practice setting is they are working particularly, with payers that can make some of those decisions to really remove some of those barriers. So it's taking that care plan I talked about. It's saying, what we've got care pathways in place. And for every patient, on every somebody we diagnose with this, these are the steps we are going to follow. It's standardized. It meets NCCN guidelines. We're using FDA information and all that information from the manufacturer to make sure we're getting the best treatment. And then trying to work with that payer, with that organization to say, if we prove to you we do this every time, can't we just do it and not really worry about the prior authorization? Because it takes a lot of time, not only on the provider side, but there's a lot that happens on the payer side too, or the purchaser side. I mean, it takes a lot to support that and go through those authorizations just to make sure that they're not doing something wrong or doing something inappropriate. We just did a study, one of the larger practices in our network, really showed that even if they go through a prior authorization treatment, they have to appeal it or, try and fight with it. 98% of the time, those go through and they're done. So why create that barrier? Why create that, hindrance to access to treatment and access to these tests?
Yeah, you're referring to gold cards.
Yeah. And I know there's been legislation that's come out and, that's really been somewhat effective, but on the most part, it really hasn't changed things. I know Ohio has a gold card, but I don't think it's been really utilized. And most of it has to do with you have to have it done within 14 days and, things of that nature. So I don't think that's been effective. And in Ohio, too, there's been, as part of the Community Oncology Alliance, we have a lot of state legislative activities we do. So Ohio did put out a biomarker testing bill. It's didn't make it through in 20. It's stuck in committee still. So it's probably going to have to be reintroduced. I don't think anything's going to happen with it this year, but it basically said that health plans, including Medicaid, must cover biomarker testing in a nutshell. So again, those are things that can help with access, but trying to rely on the legislative process sometimes is cumbersome. It's got bipartisan support, but I just don't think it's going to go anywhere. We're already, towards the end of the year, so could be bad.
Thank you. Hi, Robert. I'm Irina Smith. I'm a medical outcomes and science liaison with AbbVie. So my question is, I think it was slide 42, when you kind of show us an example when provider diagnosed patient with the cancer, and then they actually ordering limited testing versus the second example was comprehensive one. So my question is about, and then we can see in the first example, the provider, again, time passed by, they started chemo, and then they order another one. And again, it's limited, it's not comprehensive until a few weeks passes by. And then, they realize, after comprehensive, we realize here's a biomarker. We should have treated with this specific immunotherapy. Question for you is, where do you see the obstacle here? Is it always payer or insurance that is limiting or putting PA or it doesn't have coverage in a policy? Or from this example, I kind of seeing it, provider offering it twice. Are providers educated? Do they have access? Do they understand there's, availability of comprehensive testing? And from your perspective, what is that balance? Is it more like kind of 50-50? They may not knew about it, or maybe half of it, it's more insurance that denying it and they didn't know the availability or cost is too high and they don't want to cover it. Can you just kind of guide us through what's really happening on that side and the processes and the pathways, as you said, and why is this happening?
Yeah, so I think they both share responsibility. I think with the, when immunotherapy first came out, there wasn't a lot of biomarker testing, coming on when you had Keytruda and, Opdivo come out and you had to look at the PD, do that PD-L1 testing. And, when those came out, our practice, I didn't even know how much biomarker testing we were doing. Nobody was really thinking about it. I just knew sometimes they did it, sometimes they didn't, and there was no real guidelines. But once that came out, now everyone started to think about it. So providers became a little more educated and then started to discover the access barriers. But one of the things we have found out also when we did this toolkit is many of the practices that we support have used this toolkit to educate their own patients and their own providers. Because really, that's where it starts. If it's not ordered by the provider, that's really the first step. Sometimes it's very challenging to go back because if they don't and they start on a therapy or they are waiting on a biopsy result or something like that and they start something, sometimes that might negate the ability to move to a different treatment. It might make outcomes a little. I know there's research going on about that. But the key is it starts that first step with the provider and making sure they're aware of it, but also their staff too. The staff can help. The staff can do that. I mean, years ago when we got down this whole journey, they would have a 3-inch book, a notebook, a 3-ring binder of all the testing companies and stuff they had to do. All that stuff's online now. But it was interesting how it evolved from, that to really focus information, but still trying to get that information out in front of a provider is really the key first step, and then making sure that after that decision's made that the access is there.
Great. Well, let's thank Robert for his presentation and his time today. Thanks so much.
Thank you.
Appreciate it. Thank you.